My name is Wesley. I'm one of the EMIM 5. So if you haven't met me, it's probably too late now. This is my senior lecture and probably my last lecture, official lecture of EM residency. So I had a hard time thinking about what to talk about for my senior lecture. I was like, should I talk about an EBM lecture? Should I talk about right heart failure? Should I talk about some like cardiac assist device? About like bicarbonate? Should I talk about like non-medical stuff like efficiency, wellness, finances, or something like that? So I basically procrastinated, or I just waited and watched a bunch of TV. One of the algorithms online that we all love told me to rewatch Big Hero 6. If you haven't watched Big Hero 6, it's about one of the characters is Baymax, which is a robot whose goal is to improve healthcare. And this is like a snapshot of what Baymax is.
Hello, I am Baymax. I was alerted to the need for medical attention when you said, ah.
Free to download with in-app purchases. Back to the music.
Hello. Speeding and erratic driving are not conducive to good health.
Come on. Almost time.
Here, kitty. Hello. Eco.
Hey, I just have to get one more thing. Stop.
Okay. So seeing Baymax got me thinking and learning a little bit more about AI, which is what my senior lecture is going to be about. We're going to discuss what is AI, its applications in its future, how to thoughtfully approach AI in our practice. So I have no disclosures. I don't advertise myself as an expert in AI. I'm just a curious learner. And this is not going to be a comprehensive review about what AI fully is and what to do. So in 2014, Vinod Kishore, a Silicon Valley investor, said by 2025, 80% of functions doctors do will be done much better and much more cheaply by machines and machine learned algorithms. I think that's only 1 year from now. With like maximizing economic profits and minimizing potential human errors and using AI, there are talks about what role as physicians we will have in the future. But I don't think we're at that point right now, but those quotes do highlight that AI is something that we should probably be mindful in our future practice. So what is AI? Artificial intelligence, or AI, is a branch of computer science that encompasses machine learning and deep learning. It involves development of algorithms modeled after decision-making processes that learns from available data and makes classifications or predictions over time. So artificial intelligence has been around for a while. It started roughly in the concept started roughly in the 1950s. Alan Turing, a British mathematician, popularized by the movie Imitation Game, explored the mathematical possibility of artificial intelligence. Over the next century, AI research and development has grown, having successes such as like DARPA, IBM Deep Blue, which like a computer beat a chess master. And most recently in 2017, Google's AlphaGo beat an Go master as well. The biggest barrier initially to like AI's growth was the lack of computational power. Like in the 1960s, computers just didn't have enough computer power to compute everything. However, like as Moore's law predicted, the power of computation has exponentially increased in the last several decades. Now in the era of big data, like AI has its footprints in many of our processes today, such as banking, marketing, and entertainment. but AI in the medical field is still a very emerging field. In 2012, this is 2022, actually, this is a snapshot of the AI landscape in emergency medicine. As you can see, probably AI has a major footprint, mostly in self-triaging applications for patients, but has been slowly expanding to ED providers, triaging and efficiency, and also as well as population health data. So AI in the medical field, how I like to think about it, can be broken down into 3 categories: patient-oriented AI, clinician-oriented AI, and administrative and operational-oriented AI. A couple of examples, some products are like algorithms and triaging. In the one on the top left is a retrospective cross-sectional study of 170 EDs using an AI model that showed a 10% more accurate classification of ESA level 3 than triaging nurses. A retrospective analysis of 2 urban pediatric EDs of roughly 30,000 patients used different types of AI models that predicted the level of hospital level care needs for kids with asthma, measuring such as vital signs that also use weather features and CDC influenza patterns. Another example is that AI algorithms have shown to reach and exceed 3rd-year radiology residents for preliminary reads of AP chest X-rays. With products like ChatGPT or BotMD, generative AI can have now provided providers with composed notes for patient encounters. And AI can also be potentially used to predict sepsis earlier and suggest treatment strategies in critical care patients as well. In the end-of-life care, patients with cancer with a high risk of death within 6 months, an open study showed AI helped reduce the use of chemotherapy by 3%. An AI study showed that trigger palliative care decisions in outpatient primary care settings found a higher use of palliative care consultation and a reduced hospital admission rates as well. I found this one pretty interesting as well. Researchers at USC found that people suffering from PTSD are more open to discussing their concerns with virtual humans than actual humans for fear of judgment. And AI also has applications in non-clinical settings such as medical educations. I think a lot of medical schools are now exploring the use of VR for their educations. But in reality, we are already using AI tools already. However, as AI becomes more prevalent and more complex, there are some challenges and limitations to consider as well. So today I want to touch base on several aspects of AI to consider: AI safety and liability, its biases and transparency. So regarding its potential liability and safety, currently there's no single or specific regulation governing the liability of the various parties involving in AI, supply chain, nor its end users. I think in 2021, the FDA just put out a preliminary guidelines on how to look about AI and its regulations, but there's no actual full laws about how to govern it as well. So a couple of examples of liability, for example, what happens when an AI algorithm gives you a standard of care recommendation, but the actual standard of care is wrong? Is there liability in that way? But what happens if the algorithm gives you a non-standard of care, but the physician rejects it for the standard of care, but the outcome ends in the patient injury? Is there liability in that sense? Aside from privacy and other regulatory concerns, guidelines and safety rails needs to evolve with AI as it's continuing to grow. It requires a fine balance of legal liability to promote the continual innovation and improvements of these AI algorithms. Regarding biases in AI, AI systems are complex and depends not only on the code they are built, but also on the data that they are trained on. So there are potential biases in the data sets and designs, as well as potential biases in deployment of the AI as well. One of the famous studies was an Obermeyer and colleagues. They showed that an AI algorithm used by health insurers to manage care for about 200 million Americans, they reported that this algorithm systematically underestimated the healthcare needs of Black patients and excluded them from eligibility for expanded care management services. When they dig deep into this algorithm, they actually found that the algorithm chose, out of all the data points, patients' annual health care spending as a proxy for the health status. So people who spend more for the healthcare system, healthcare needed more healthcare services. But we also know from our patient population that many of our Black patients on average don't spend as much on their healthcare spending, considerably less than the white patients in the same medical conditions. Another famous example came out in an article of summer 2023 with Google's facial recognition software. The software was revealed to have trained primarily on photos of white individuals and initially placed photos of Black individuals into a folder labeled as quote unquote gorillas in the early phases of development. So like AI works based on its data set. So if the data set is biased, then its predictions as well are biased as well. So something to be aware about as we get to use more of our AI products. On the other side of the spectrum is like over-reliance on this technology. In one study of like machine interpretation of atrial fibrillation ECGs, 9.3% of these interpretation had errors, understandably. Of those ECG erroneous reads, 7.8% were not corrected by a physician interpreting the ECG at the time, leading to unnecessary tests. This is like an example of automation bias, which is erroneous assumption of an incorrect automatic interpretation. By recognizing that AI models have difficulty to accurately represent a diverse population, it can lead to biases and inaccuracies or even failure, which is important. Over-reliance may lead to a decline in like decision-making skills, which can potentially compromise patient care if a physician does not recognize an erroneous AI response. Dr. Iverson, a professor emeritus of emergency medicine at University of Arizona, cautioned that the rapid availability of AI programs fueled by vast electronic health record data sets has led to an increased pressure on hospitals and clinicians to embrace clinical AI without comprehensive system evaluation. So I think we should, and that leads to my next point of transparency. Dr. Iverson wrote in 2024 that AI's complexity can potentially surpass emergency physicians' capacity to provide patients with informed consent regarding its use. He suggested that emergency physicians should have at least 7 key areas, understand at least 7 key areas regarding AIs to provide informed consent. And those 7s are 1, how AI systems operate; 2, whether AI systems are understandable and trustworthy; 3, limitations and potential errors; 4, how disagreements between physicians and AI are resolved; 5, whether PHI are secured; 6 is validity; and 7, and its biases in these algorithms. Like any procedures, we should know the benefits and risk of using AI products. So how should we approach AI? What is our doctor-patient relationship and potentially our machine relationship that we should have? Like AI can be considered, I think, like a medical device, and like any device or procedure, it requires the operator to have a level of experience in explainability as well as in interpretability. Like explainability refers to really understanding the mechanism behind what the operation of the algorithm is. And whereas interpretability refers to the meaning of the AI system output, requires us to understand the risk and benefits of how it produces these outputs, as well as how to interpret these outputs as well. On the flip side as well, as we incorporate AI into our practice, we as physicians must be aware that often patients do not want to have to interact with humans and not really with an algorithm. So they should have the right to refuse AI in their care, and allows for autonomy as well with their healthcare. At the end of the day, too, patients and we are as providers are the end users of AI. Technology comes out best if it's built in concert between the intended user group, like by eliminating silos and by fostering collaboration between patients, healthcare systems, professionals, industry representatives. Products and services of AI can be made for us as providers as well as for our patients' needs. I think probably a good example is the Queen of Heart AI algorithm by PM Cardio. It's been shown like with good data sets now that it's been able to diagnose about potentially 39 cardiovascular diseases. I think we're part of a study to help validate its findings. But it shows an example of that, of this iterative kind of process that we are doing with AI as well. So like WHO suggested that the AI tools should be, and applications should be evaluated with the same scientific rigor like any other product. And physicians should advocate for the liability coverage that aligns with professional standards of care with the use of AI in EM. So in summary, I hope my presentation provided a framework, at least, and like a groundwork to think about AI. In summary, AI is growing in its breadth and scope. I don't think it's growing anywhere, and it's probably going to be very integrated in our practice. Despite its potential uses and growth, be rigorous in understanding its safety profile, its liability, and its biases and ethical issues. Automation bias is scary and should push us not to be complacent in our training. Be transparent with AI in your practice. And also just like by becoming a little bit more literate about technology, you can help become more involved to make a better product as well for the future. These are my resources. Yeah. I also wanted to give like quick 5-year reflection. It's been a long 5 years, but took another inspiration from another anime series, Avatar, Last Airbender. With Uncle Iroh. Life happens where you are, whether you make it or not. It's important to draw wisdom from other places. If you only take it from one place, it becomes rigid and stale. Understanding others, the other elements, the other nations will help you become whole. Sharing tea with a fascinating stranger is one of life's true delights. And lastly, there's nothing wrong with letting people love you and help you. So remember your why, about why you became a doctor, why you're in this program, why you're here. My why has changed in the last 5 years multiple times, but it's been an amazing journey. Be a student always. Make sure that like medicine is constantly evolving, and I don't think what I learned 5 years ago applies to what I'm doing now sometimes. Be positive and enthusiastic. I think I've learned so much from you guys, as well as to the nurses, the PCAs, to like off-service people, to consultants that I've built alliances with a lot of them, and it's for patient care. And then lastly is automate as much as possible. Cognitive load, whatever, it's not important as well. I think Paul did a great job of last time on his senior lecture about what to talk about, how to cognitive offload things as well. Yeah, so I'll end with a few thank yous. First off, thank you to our leadership, Dr. Schechter, Dr. Willis, Dr. Smith, Dr. Gennaro, Dr. Hassel. I wrote your name right, Dr. Gennaro, just letting you know. Dr. Macho, Dr. Buckridge, thank you for your hard work and your support and your what you do for our residency. To our EM faculty, Dr. Sinner, Dr. G, thank you so much for what you guys have taught me, and the IM faculty and ICU faculty as well, these 5 years. Thank you to my co-residents, especially my class. You guys are amazing doctors. You guys inspire me not just in the clinical settings, but by your advocacy and by your social justice and your amazing outside pursuits as well. My class, can't thank them enough. To my EMIM peeps, you guys are unique and weird, just like me. Not to mention insanely smart. I appreciate you all, and I appreciate all your help in these 5 years. To my EMIM class, I think I see John only. Thank you, John. Could not wish for 3 other people to have gone through a pandemic together, countless of joys and hardships together. To my family who have supported me from the beginning, and lastly to my wife, who has been my rock throughout this entire journey. So yeah, thank you, guys. Oh yeah, my cat. Thank you.